This episode is brought to you by the American Urological Association.
Good afternoon. My name is Jay Rahman, and I'm professor of urology at Penn State Health and chair of the AUA's Office of Education. I want to thank you all for joining us for another episode in our educational podcast series, with this specific episode titled Recognition and Management of Complications Following Gender-Affirming Surgery. Joining me today is Dr. Laura Douglas. Dr. Douglas is assistant professor of urology at the Temple University School of Medicine. She's a reconstructive urologist who also has a practice in gender-affirming surgery and has been really kind enough to give us about 30 to 40 minutes in our afternoon, even canceled her clinic a little bit early to join us on this podcast. So Laura, delighted to have you. Thank you so much for taking some time out of your afternoon to join us on this podcast today.
Thanks for having me. I appreciate it.
So maybe what we'll just start off and talk about is, obviously I think gender affirming surgery is even in the world of urology, it's a very niche area. Most places, most academic centers maybe have one person, maybe at the most two doing it. But I do think that there's probably a lot of themes that are important for all of us, even if we don't specifically do those types of operations. So maybe just to kick it off, I'll ask you, a real basic question. The stuff we're going to cover in the next half hour or so, why is it important for really all urologists or all urologic practitioners to know about?
So that's a great question. And you're absolutely right. A lot of times you're going to find very specialized academic centers with multidisciplinary gender affirming surgery programs. But I do think this is really important for all urologists to have a basic understanding of gender affirming care in general. While you might not be specifically performing gender affirming surgery, you may very well end up having a transgender patient coming into your clinic for urologic concerns. So just some of the basic principles of gender affirming care, I think, is important for urologists to understand. And importantly, I always like to reframe this for all urologists. A lot of us already are providing gender affirming care, even if we're not doing gender affirming surgery. So when we treat sexual dysfunction, that is very gender affirming. When we prescribe PDE5 inhibitors or place penile prostheses for erectile dysfunction, incredibly gender affirming for our patients. When we are supplementing testosterone replacement therapy for our patients with hypogonadism, again, very gender affirming. So as urologists, we already are providing gender affirming care. I think it's important to be inclusive, that we can provide gender affirming care for all of our patients. So, specifically, when we get kind of further into discussions, I'll try to keep it more general, more broad for, the general urologist. What might you see in the emergency room that you might get consulted for, and what might patients be coming into your clinic to see you for?
Great. No, that's super, really, really nice summary to get us kicked off here. So, we have titled this, and obviously we use the term gender affirming surgery. And, maybe before we even dive into maybe some of the complications or maybe the follow-up afterwards, maybe just, give us the high level, the 20,000 foot view on, what is gender affirming surgery? What is that in female gender affirming surgery, male masculine gender affirming surgery? Talk to us about that, and what are sort of the steps of the operation, and what you think is important for all of us to know about.
Sure. So gender affirming surgeries is kind of a broad term that describes surgeries that help better align a person's physical characteristics with their gender identity. For our transgender folks, very often their current anatomy does not align with their current gender identity. So that's just kind of a broad overview of what gender affirming surgeries are. I think the surgeries and the points about these surgeries that's important for a general urologist to know is, first, when we talk about feminizing genital gender affirming surgeries. So first is orchiectomy. So orchiectomy, all urologists, we know how to perform orchiectomies. We do them for different indications, for cancer, for torsion. Certainly the general urologist in the community, especially if you're in an area where there is not an academic center or a very large or busy gender affirming surgical practice, in a wide radius. Patients may be coming to your office seeking gender-affirming orchiectomy, which, depending on your level of comfort, is well within our technical skills. The biggest point I want to point out here for gender-affirming orchiectomy is often the technique is somewhat modified so that we don't burn any bridges for future reconstructive surgery. So we really want to minimize scarring of the scrotal skin. So try to make a single midline incision in the high penoscrotal area to minimize scarring of that scrotal skin that may be used as a full thickness skin graft for vaginoplasty. And also trying to preserve as much of those surrounding tissues as possible, trying to peel off that layer of soft fatty tissue off the testicle spermatocord, try to save as much of the tunica vaginalis that you can. So those tissues are available for future reconstructive surgery. So certainly orchiectomy well within our skill set as urologists. For the full bottom surgeries, typically we're talking about vaginoplasty or vulvoplasty. The difference between vaginoplasty and vulvoplasty is vaginoplasty is specifically talking about the creation of the vaginal canal. So this is for a patient who desires a full depth vaginal canal. A vulvoplasty, or what is sometimes called as a zero depth or a shallow depth vaginoplasty, is creating the external genitalia, the vulva, and not creating the canal, the vaginal canal.
Okay.
So that's kind of the big overview of feminizing surgery. One important distinction when we talk about vaginoplasty is there are really two techniques that people should have just a general idea of. So the first technique is the most common in the United States, which is the penile inversion vaginoplasty technique. That's where we use a combination of the penile skin and a scrotal skin graft to line the vaginal canal. One of the other techniques, really innovated by our very own Dr. Lee Zhao at NYU, is the robotic peritoneal flat vaginoplasty. And we are starting to see more centers starting to offer robotic peritoneal flat vaginoplasty. Dr. Lee is incredibly generous with his time and education and teaching, and our team has gone up to NYU to learn this technique, and he's trained multiple fellows who've gone off into their practices. So you may start seeing more patients who've had robotic peritoneal flat vaginoplasty. Biggest difference here is that the deepest part of the vaginal canal is lined by peritoneal flaps. And so we need less skin. We need less skin to line the vaginal canal, and potentially this technique is helping to achieve a more consistent vaginal depth for our patients. So definitely some nice benefits of the robotic technique, and you'll likely see more patients having this technique done in the future.
So that's the feminizing genital gender-affirming surgery. Maybe take us now to the other side, which is some of the nuances of the masculinizing gender-affirming surgery, and then we'll maybe use that as a starting point to talk about maybe the types of things that we could see as sequelae thereafter in aftercare.
Yeah, absolutely. So for masculinizing genital gender-affirming surgeries, there are various procedures that kind of fall under the purview of urologists. So the first is metoidioplasty, or sometimes the nickname is meta. You might hear people refer to it as a meta. So metoidioplasty is the creation of a smaller neophallus using the hypertrophied clitoris. And this technique really was innovated by urologists. A lot of these techniques are coming from our pediatric urologists and hypospadia surgeries. So metoidioplasties can absolutely be done from start to finish by urologists. So metoidioplasty falls under the purview of urology. Metoidioplasty can be performed with or without urethral lengthening, with the goal of urethral lengthening being that a patient will be able to stand to urinate. And so this urethral reconstruction, there are various techniques, and that might involve using buccal mucosa graft. So really, really going back to our kind of reconstructive urology experience and use of buccal mucosa. And so you may see patients with metoidioplasty with the urethral lengthening. the kind of very large surgery that isn't so much done by the urologist is the creation of a larger neophallus, a full phalloplasty. This is typically a flap surgery, most commonly a radial forearm free flap or an anterolateral thigh flap. We work with plastic surgeons for this, absolutely, but really the flap creation is under the purview of a microvascular plastic surgeon colleague. As reconstructive urologists, we're typically there when they're ready for the urethral hookup, the urethral anastomosis for the full urethral lengthening. So often for phalloplasty is a joint venture with both plastic surgery and urology. And then the other two surgeries are things that we're more familiar with, just not necessarily in this setting, is testicular implants. Scrotoplasty with testicular implants is absolutely a part of these masculinizing bottom surgeries. Scrotoplasty with testicular implants. And then one of the very last stages of masculinizing genital gender affirming surgery is penile prosthesis. Placement, so having a prosthesis.
So that was great. I think that helps sort of. I think most of us that don't do this a lot to at least get a sense of the terms, the elements that are a little bit more unique for feminizing versus masculinizing. So let's use sort of what you just talked about, and maybe let's talk about what maybe all of us can see afterwards. And maybe we'll break it into two components. Maybe we'll first break it into the type of maybe complications or consultations. I guess consultation is probably a better word. Consultations that may occur in more of an acute setting, maybe like emergency department or early representation after surgery. Maybe talk to us a little bit about what some of those are. And then maybe when ballpark, if there's a timing for some of these events. I mean, maybe they don't all occur in the first 3 to 5 days, but maybe if you could talk to us a little bit about what are we going to see, maybe a little bit about how to manage some of them, but also the timeline that we might see them afterwards.
Sure. So, I do want to point out that a lot of patients travel to have their gender affirming surgery. So they may travel across the country, have their surgery there, typically stay for a few weeks afterwards, and then return home to wherever you may be practicing. So it is completely possible that a patient shows up in your local emergency room. They've had surgery in California or somewhere totally remote from where you currently are because they're actually local to that area. So I do think kind of having some knowledge, so when the ER calls you, that you can feel a little bit more comfortable, like, okay, all right, I can handle this. I, have a general idea of what to be looking out for and how we might manage some of these issues. I think that will be really helpful to everyone. So in terms of the more acute issues and calls that you might get from the emergency room or from the hospital. So first, the thing that comes to mind is urinary retention. So after vaginoplasty, patients have a urethral catheter. It's typically removed on the last day that they're in the hospital, and patients pass a trial of void. But it's completely within reason. Just from surgery, the vaginal canal dissection is right under the urethra and prostate and bladder. Having edema, swelling, if there was any preoperative voiding dysfunction before surgery, then they might go into acute urinary retention. And they're going to show up in the emergency room, and emergency staff is not going to be very familiar or comfortable with postoperative surgical anatomy and how to place a catheter. Placing a catheter in someone after a vaginoplasty is actually very easy. The urethra is significantly shortened. So, and a lot of our patients have smaller prostates because of hormone therapy. So typically the catheter placement itself is not difficult, but kind of locating the urethral meatus could be a little bit challenging. So for the most part, the easiest thing, kind of just understanding the general anatomy, is the urethral meatus is going to sit right on top of the vaginal introitus or the opening to the vaginal canal. And the opening to the vaginal canal will likely be much more obvious. In comparison to cis women, the urethral meatus is actually much closer to the vaginal introitus. So it's literally going to be right on top. Sometimes people actually dilate their urethra instead of their vaginal canal because they are so close to each other. And really, you're looking for the pink mucosa of the urethra. And often we're preserving the dorsal plate. And so you can kind of see this nice, shiny pink urethral mucosa, and you can kind of use that. It'll be in the midline, and taking your catheter and starting there and just keep dropping that catheter closer to the vaginal introitus, and you should be able to find the meatus and pass the catheter. And again, the urethra is significantly shortened at that point. So placing a catheter should actually technically not be difficult. Standard 16 French, should be fine for getting a catheter in. For after masculinizing bottom surgeries with urethral lengthening, this gets a little bit trickier. So the urethral lengthening, can be an additional segment or 2 segments of urethra using buccal mucosa. In general, you'll hear, yes, you can try one attempt at a blind passage of like a 14 French silicone. But really, if someone is in retention after having urethral lengthening, either you want to get a catheter under vision. So using a pediatric cystoscope or a ureteroscope, you're very unlikely to get the standard 17 French flexible or a rigid scope. It's very unlikely you'll be able to get that in after urethral lengthening. So you can try to place a catheter over vision, over a wire, cystoscope and wire, and a catheter over the wire. But honestly, probably the safest thing to do would be to place a suprapubic tube. Either, yourself at the bedside or having IR colleagues place a suprapubic tube. And the patients have likely already had a suprapubic tube. That's kind of part of the standard post-op pathway, is that they'll have a suprapubic tube for some time after surgery. So they're likely already very familiar with suprapubic tubes. So that's probably the safest option if you have concern for a stricture and retention after masculinizing bottom surgery with urethral lengthening.
Okay, so retention, that was really good. And I thought it was really nice how you differentiated between the challenges or the differences between the 2 different types of operations. What about bleeding? Talk to us about bleeding complications after these procedures.
Sure. So, of course, bleeding after any surgery can really happen from anywhere, but I'll kind of talk about the most common causes of bleeding after surgery and how you might be able to manage it. So certainly people can develop hematomas after surgery. Most common after vaginoplasty is a labial hematoma. You might notice significant asymmetry of the labia, and you'll be able to palpate kind of a hematoma, or you might notice very significant ecchymosis or bruising. What can be done? You can drain a hematoma. If hematomas, you don't necessarily have to drain them if they're not causing any major issues, but if it's pretty significant, you can open up a few of the stitches at the bottom of the labia and see if you can drain any of the hematoma through that. What we tell our patients, it's pretty common to have some hematoma drain for the labia. It's that classic dark purple, that old blood look. It can be very alarming to patients, but often we reassure them that, hey, this isn't fresh bleeding. This isn't active bleeding. This is kind of old hematoma. We would rather it drain from you rather than staying inside. And so sometimes we'll tell patients, you might have a hematoma drain for the next week or 2 as it kind of liquefies and works its way out. So if you need to, you can kind of open up a few stitches in the labia if you have any concern for a hematoma. The most common, I would say one of the more common causes of bleeding kind of in that immediate post-operative period, those first few weeks, is the urethra. The urethra, as we know, the sponge, the corpus spongiosum, loves to bleed. And so that is a very common culprit of bleeding immediately after surgery. A lot of times with direct pressure, making a pressure dressing, putting some Surgicel, that bleeding, will often resolve just with some pressure. but you may have to place a few, if you can see the exact area that's bleeding, you can try to place, a figure of 8 suture to try to get the hemostasis. And if you end up doing a sort of kind of like pressure dressing, compression dressing, you may want to put a Foley catheter in so that the patient doesn't have to worry about trying to pee with like a big kind of pressure dressing on. So really kind of our principles of hemostasis is really helpful in the setting of bleeding. Another source of bleeding that you might see is bleeding from the actual vaginal canal, especially as patients are dilating. Usually these are hard plastic dilators. They're hard plastic or silicone, and they're dilating areas that are trying to heal. So sometimes people can get into bleeding with their dilations. And typically you can just take, some vaginal packing or Curlex and just pack the canal and leave the packing in for a few hours, and the bleeding will typically stop. So those are some basic ideas for, how to manage any postoperative bleeding.
So this is obviously a really complex reconstructive type procedure, and I would imagine that if we broadly use the term sort of like wound complications, there can be complications attributable to this reconstruction, elements of the reconstruction, a lot of obviously suture lines and so on and so forth. Maybe talk to us about wound complications, and maybe blend in, I'm sure infection is part of that, but maybe talk to us about infection as well as other associated wound complications from this operation or these set of operations.
Sure, absolutely. So these surgeries are the pinnacle of reconstruction and tissue rearrangement. I've learned a lot from operating with my plastic surgery colleagues about flaps and blood supply. And so it's been really great to kind of learn more about wound management in this setting. So absolutely something that you might see kind of in that acute surgical period are wound infections and cellulitis. So this will be the classic kind of erythematous, indurated, tender, bright red wound infections, and treat that as we normally would with antibiotics. Try to cover, our typical skin flora, MRSA, typically like Bactrim for any concerns. Make sure there's no concern for an abscess or a fluid collection. Something that I have been noticing a little bit more is sometimes patients actually end up having a fungal wound infection. So sometimes if they're not responding to the typical, antibacterial or typical antibiotics, is consider in the back of your mind of a fungal infection. Something that is very common that patients will call about is they'll kind of see this yellowish, whitish tissue and its drainage, and everyone calls it pus. They'll say, I have pus coming from my wound. And a lot of times it's fibrinous tissue. And it's sloughing. It's very common, especially with a lot of significant tissue rearrangement, to have some necrosis of the tissue. Not all of the tissue sometimes has good blood supply. So it may kind of slough, and underneath it should be nice, healthy granulation tissue. But that's a pretty common thing that patients will say, I think I'm having pus, and you'll see this like whitish, yellowish tissue. And you can treat that if there's, you can do some gentle debridement if there's a lot of non-viable tissue. But honestly, it's local wound care, keeping the area clean. They can do sitz baths, letting that area slough off. If you have concern for infection, you can always cover with antibiotics. But more often than not, it's our kind of typical fibrinous tissue. So yes, gentle debridement if you think it would be really helpful. I kind of mentioned a lot of the tissue rearrangement and some of the necrosis. That goes kind of hand in hand with one of the most common wound complications after vaginoplasty is wound dehiscence. And it is most common at the posterior labia close to the introitus. And that's because that tissue is tissue that had to travel. It was literally higher up, closer to the phallus, and we're bringing it all the way down to the introitus. So that area, those suture lines are going to be on the most tension. And the tissue that's on the most tension is most likely to have some of that non-viable tissue, have that sloughing, and then to have that wound separation or that dehiscence. Again, it can look frightening, especially to patients, to see wounds separate. But again, with local wound care, typically these wounds will heal very nicely. It's just kind of reassuring patients, and local wound care, betadine sitz baths can be helpful, and helping that tissue slough off and having the healthy granulation tissue fill in. And again, most of the time, once they've healed up, it looks remarkable. It's amazing how well these areas can heal. Another common wound issue that you might see in the acute setting, but also in the clinic, is granulation tissue. So granulation tissue is part of the normal healing process, and kind of having that beefy red kind of pink tissue that comes up underneath this kind of sloughing or fibrinous tissue. You might also see it at areas of fistulas, so a urethral-cutaneous fistula after masculinizing bottom surgery. Granulation tissue in itself isn't a bad thing. It's part of normal healing. A lot of times it will just heal and regress and epithelialize, but hypertrophic granulation tissue can cause pain, it can cause bleeding, it can cause discharge. It can be common within the vaginal canal itself. So, if someone presents with vaginal bleeding, doing a speculum exam to see if you can see any areas or bleeding, you might see that hypertrophic granulation tissue. Typically, we can treat that with silver nitrate. So silver nitrate sticks tends to respond very nicely to silver nitrate treatments. Can do more aggressive, like curette or sharp excision of granulation tissue in the clinic or in the office, but silver nitrate tends to work really well for granulation tissue. And the last thing I wanted to mention, that thank goodness is not very common, but if you do see it, that you can remain calm, is to have prolapse of the vaginal graft out of the canal. And it can be very disconcerting to patients. They'll kind of call and say, and this might be, a week or two after their vaginoplasty, where the skin graft inside the vaginal canal did not take for whatever reason, most commonly hematoma or infection, or most common causes of graft failure, is they'll have complete prolapse. And so it'll kind of look like this little sock of non-viable tissue, the skin graft, and it'll typically have that yellow whitish appearance. And it'll just kind of be hanging out of the introitus. If the skin graft still looks like skin, if it still looks like it has any chance to be viable, you can always try to put that skin back into the canal and try to repack that canal. At that point, it's not likely that skin graft will retake, even if you do repack it. So if it doesn't look like skin anymore, if it just looks completely necrotic, that yellow white tissue, you can sharply excise it. And then it's really important that the patients continue to do their vaginal dilations. Without that kind of epithelialized surface in the canal, that granulation tissue is really going to want to seal that space back down. So it's really important that they maintain their dilations. And of course, a lot of these complications is you're doing your best to help out locally. Is that patients really should be calling their primary surgeons as well. And primary surgeons were happy to help our local colleagues out, helping us manage our patients locally. So because some surgeons may want to bring a patient back immediately to regraft the canal, other surgeons may not want to regraft. So there's a little bit of debate about whether to immediately regraft the canal or not. So the primary surgeon will hopefully be easy for you to get in touch with, or the patient. We're usually very grateful to our colleagues to help out.
So let's maybe transition the last 5 or 7 minutes or so, and let's talk about We've talked a little bit about some of the early acute complications you could see. What about maybe stuff that's a little bit more distant? So maybe stuff that may present in the office and the clinics, maybe not 3 to 5 days, but maybe months or even years later. Talk to us over the last few minutes about some of those issues that may surface down the road.
Sure. So I think something that might be very common to kind of end up in your urology clinic are recurrent urinary tract infections after gender affirming surgery. It's something that they might not think immediately to go, oh, hey, let me call my surgeon for. It's been, a few months to years later, and may seek local urology care. So one thing to keep in mind, especially after vaginoplasty, are the changes in anatomy. So after vaginoplasty, as I mentioned, the urethral meatus is sitting very close, right on top of the entrance to the vaginal canal, which is very close to the anus and the rectum. So now where we're peeing from is now much closer, and it's a much shorter urethra now to where a lot of our enteric flora is coming from. So the urethra is much closer now, and it's also shorter. So these are all potential risk factors. Also, after vaginoplasty, one of the big differences after vaginoplasty compared to cis vaginas is the local flora. And after vaginoplasty, typically don't have the benefit of having that normal genital flora that keeps a low pH to help prevent urinary tract infections. So there's actually been some studies into this, studying the kind of flora and the microbiome of a vagina after vaginoplasty versus someone born with a vagina. And there's been talk about, could probiotics be helpful, whether it's taking the probiotics orally or doing a probiotic douche. A lot of this is kind of anecdotal. Our team will kind of recommend just probiotic douches every other day, just to help with normal, healthy genital flora. But again, a lot of this is more anecdotal. There is some emerging evidence as people are kind of studying this flora a little bit more. So these are definitely risk factors for recurrent UTIs. Always kind of the standard evaluation. Does the person have underlying voiding dysfunction, checking a PVR? Are they emptying their bladder well? Kind of the standard approach to evaluating for a recurrent urinary tract infection. And typically similar approach to managing the recurrent UTIs. You can acidify the urine, your Hiprex, your vitamin C, your cranberry supplements, time voiding if they're not emptying their bladders well. So kind of the standard approach, but just keeping in mind what are some of the unique risk factors for recurrent UTIs after vaginoplasty. Certainly after masculinizing bottom surgery, one of the most common complications after masculinizing bottom surgery are urethral complications. Stricture, fistulas. So these can all be things that can cause recurrent urinary tract infections afterwards. So again, assessing for, elevated PVR. If you have concern for stricture, you could try to do a cystoscopy. You could try to get some imaging like a rug, but ultimately probably their primary surgeon or a reconstructive urologist. Most strictures need to be surgically managed. Small fistulas may close up on their own if they're small enough, but if they persist, someone's going to be telling you, I pee from 2 holes, typically areas of anastomosis of the urethra. So you can see that with fistulas.
Talk to us a little bit about the different types of fistulas. What could fistulize, and maybe just speak a little bit about that.
Sure. So in terms of fistulas, the first thing that comes to mind to me is urethral-cutaneous fistulas after masculinizing bottom surgery. So I kind of mentioned, patients they're usually picking up on it first. They'll say, that there's urine coming from a different location than just the tip of my penis. But when it comes to vaginoplasties, thank goodness these fistulas are quite uncommon, but something you want to think about is patients can get a urethrovaginal fistula. The biggest thing they'll be complaining about is kind of pooling or leakage of urine, where the urine is draining, and some of the urine is draining into the vagina. So they might complain to you kind of almost like incontinence. When I stand up, all this urine starts to drain out. Or they might notice that every time I pee, I'm peeing from my vagina. So that might be something that patients might notice. And then rectovaginal fistula is probably one of the most dreaded complications from vaginoplasty surgery. Typically, patients are noticing this within a few weeks after their surgery, and the classic symptoms are going to be passing stool or gas from the vagina. And then typically you're going to want to get the primary surgeon updated, but may involve doing a bowel diversion with colorectal surgery, and then after diversion, talking about repairing fistulas with the principles of fistula repair, interposing tissues, separating the two, the two different systems. So likely that'll be something more for your reconstructive colleagues to manage, but would be a very good thing to pick up on if you're able to pick up on that in the clinic.
And then maybe really briefly, vaginal stenosis, vaginal bleeding. You alluded to this a little bit early on, that in the setting of using dilators and dilation, but talk to us a little bit about that just as a finishing point. How often does that occur? And is the bleeding really related to the dilation, or is it distinct from that?
Sure. So luckily, vaginal stenosis is not super common. Certainly we can see it maybe 10 to 15% of the time. Typically related to lack of adequate dilations. For various reasons, patients may not dilate regularly. And that might be because of pain, because there are wound complications. Dilations can be very triggering. They can be very dysphoric for some patients. They're tough. And patients have to really commit to doing them daily, especially in that first year. That's when the inflammation and scarring in that first 6 months is the most intense. So the dilations are really the one tool we have to counterbalance the natural healing process, which is to scar. And scars want to scar down, they want to contract. So the dilations are really important for this. So patients will often, they'll kind of come in and they'll tell you, they're just like, yes, I've lost some vaginal depth, or, I didn't dilate for a few days or for a few weeks. And now I can't get my dilator back in, to where it was before. The way you can manage this is I recommend get them plugged in with a great pelvic floor physical therapist. If they recommit themselves to their dilations, they may be able to regain some of that vaginal canal, some of that depth back. I've seen patients work really hard and, get that canal back. But if they can't, then ultimately there are revision surgeries, revision vaginoplasty to recreate that vaginal canal. It is riskier though, because now that plane in between the urinary tract and the rectum, it's gone now. It is scarred. So the risk of a rectal injury is definitely higher in a revision vaginoplasty setting. So in my opinion, the best technique for this is robotic. Is you have a robotic surgeon who's working from the abdomen and they're going from known to unknown, and you have a perineal surgeon who's working from below. And the robotic surgeon can kind of see the rectum and help hopefully kind of keep it out of the way. So I do think getting them plugged in, with somewhere, a center or a surgeon who's doing the robotic technique for revision vaginoplasties is probably the safest.
Great. Well, Laura, that was really super. Really appreciate you walking us through. I think you really, summarized what is obviously a very niche and nuanced field to, I think, what many people may encounter in practice. And I think, as you sort of alluded to, it's very much, I think, for those patients that travel, a partnership between the surgeon and maybe those that are going to help care for them in a more local environment. Because of just the travel associated with that. So really want to thank you for your time, obviously for your expertise and carving out a little bit for us this afternoon.
Great. Thank you so much for having me, and reach out if you have any questions.
For our listeners, we thank you very much for joining us. Please join us at auanet.org/university, and we'll certainly add to this podcast some of the articles that Dr. Douglas thinks are very relevant in this space. And for those of you that want to do a deeper read into it, we'll certainly have those available for you. Laura, good seeing you. Thank you so much once again.
Thank you.